Hello and welcome to another episode of Keeping London Healthy. My name is Dr. Elia, and we have an exciting episode today where we're dealing with a topic that really doesn't get enough attention in medicine, and that is obstructive sleep apnea. Probably one of the things I see in practice that needs more attention and not enough people know about. So we brought in Dr. Christopher Lee. He's a respirologist and sleep disorder specialist in Toronto to answer some questions that we have for him today. And we'll be back with Dr. Lee right after this break. Welcome back. I'm pleased to introduce our guest for today, Dr. Christopher Lee. Dr. Lee, if you can tell us a little bit about yourself.
Oh, thanks, Mario. I'm a respirologist and sleep disorder specialist. I work at St. Michael's Hospital in Toronto. I see a lot of people with a variety of sleep disorders, but a big part of my practice is patients with sleep disordered breathing or sleep apnea.
What is sleep apnea? Because I know a lot of people still have some kind of misconceptions about what that is. So how would you, what is sleep apnea?
An apnea is just the term that we use for a stop in breathing. So when we're talking about people with sleep apnea, we're talking about people who have repeated stops in breathing during sleep. Now, even normal people can have a few pauses in their breathing. That's not unusual for people to do that a little bit during their sleep. But people with sleep apnea have more frequent apneas, which tend to result in repeated awakenings and disrupted sleep. Sleep apnea can occur for a variety of reasons, but by far the most common type of sleep apnea is something that we call obstructive sleep apnea. So this is a condition where the throat becomes blocked or obstructed during sleep, which results in stops in breathing that happen over and over again during the night.
What are some clues to look out for patients that they may have sleep apnea and may not be aware of it?
That I think goes back to maybe the best way to explain this is to describe a little bit about why people actually develop obstructive sleep apnea, and that kind of explains why people present with some of the symptoms that they do. So if you think about your throat's kind of like a tube, right? There's a bunch of muscles that help to keep the tube open. But when you go to sleep at night, the muscles relax. And so the tube can kind of collapse on itself. Okay. So when the tube collapses, the flow in the tube becomes disrupted and we start to hear vibrations, which is the tissues sort of banging up against each other. And that produces noise, which we hear as snoring. In some people, there's complete collapse of the throat, which leads to this complete obstruction in the tube, and that causes the apnea part of sleep apnea. When a person has an apnea, what happens is their oxygen levels start to come down because now you're not getting new oxygen into your lungs. And so when that happens, the brain responds to this by waking you up. Sometimes people remember the waking up part, but a lot of the time they don't. When the brain wakes up, though, it tells the muscles to start working again. So they open up the throat, air starts moving back and forth again, and the oxygen levels sort of come back up, which is why, generally speaking, people don't just drop dead from this in the middle of the night. They tend to wake up from the apnea and resume breathing again. But once everything resumes normal breathing, people go back to sleep, and then the muscles relax again, and the whole thing can happen again. So this results in a number of fairly classic symptoms from sleep apnea. Snoring is a very common presentation. So snoring is common in the general population, but almost everybody who has obstructive sleep apnea is a snorer. It's very common for us to have patients come to us mostly because their partner has noticed that they're snoring a lot and it's been disrupting their sleep. Sometimes people with sleep apnea will find that they wake up a lot during the night, and sometimes they feel like they actually wake up with a choking sensation, but sometimes they just feel like they're waking up frequently during the night and aren't really sure why. And then people often present with symptoms of disrupted sleep. So they may feel like they wake up in the morning feeling unrefreshed. Sometimes people wake up with headaches or feel very tired and sleepy during the daytime. And then finally, during the daytime, there can actually be some effects from the sleep apnea. So people often notice that they're tired during the day because they're not getting a good sleep at night. They feel drowsy. They start to doze off during the day when they're not intending to, or they feel like they have to take naps. These are all some of the typical symptoms of sleep apnea.
It's interesting from the referring physician standpoint. So again, people are presenting to me with their initial symptoms. The only time I really ever have patients actively request a sleep study is when they're their partners complain about their snoring, or their partners complain or has noted that they're stopping breathing during the night, and that kind of raises the alarm bells of sleep apnea. But I would say the majority of the time when I'm initiating the sleep study and the patient had no idea that this was a possibility, it's often that fatigue and that unrefreshing sleep, sometimes the headaches that are driving that. When patients come to you, obviously they've been referred for the sleep study, you're diagnosing them with that. Would you say a lot of patients are kind of surprised by the findings, that they weren't aware of the severity of the sleep apnea, or that they even had sleep apnea to begin with?
Yeah, I would say that's very common. And so that, as you point out, there are some people who come because they feel tired, and they start to sort of put together the pieces of the puzzle and figure out that, maybe there's something wrong with their sleep. But because sleep apnea is a very common condition, and it's not something that happens to people sort of suddenly. Often people just get used to feeling a certain way and don't really recognize that they actually feel lousy and that they're tired all the time, or that people just sort of figure that it's normal aging, or they're too busy, or not spending enough time sleeping, which can all be the case as well. But it's harder for people, I think, to make that connection between how they feel during the daytime and the sleep apnea at night. And so you're absolutely right. A lot of the time, it's people are coming to see us because their partner is just sick of the snoring and can't put up with it, and gives them an ultimatum that they better get this taken care of, or else. So that's something that we see very common.
And risk factors for sleep apnea? I'm not sure if you can touch on that a bit.
There are a number of things that sort of put people at risk of sleep apnea, but and some of them are things that we get on history when we talk to a patient. So that snoring history is one that often goes along with sleep apnea. And sometimes people are actually aware of choking and gasping sensations and daytime sleepiness. But when we look at a patient, there are certain anatomical features that also make people more predisposed to having sleep apnea. So people who have a larger neck size have a higher chance of having obstructive sleep apnea. And so being overweight often goes along with that. In men, we often ask about the collar size, because men often know what their neck size is for dress shirts, even though everybody seems to have stopped wearing dress shirts these days. But when people were still wearing dress shirts and going to the shirt section in the department store, they would often know their shirt size. It seems that a shirt size or a collar size of more than 17 inches is in and of itself a risk factor for having sleep apnea. And if you have some of those other historical features like the snoring and choking and gasping spells, that increases the risk. Other anatomical things that can predispose to sleep apnea would include having a relatively large tongue for the size of the mouth. Some people have a jaw structure that also puts them at some risk for sleep apnea. So if you have a jaw that's kind of set back or small, then that can sort of reduce the size of the airway as well, and make people a bit more prone to having sleep apnea.
And again, these are all risk factors that we often see. And the thing I point out to people often is that even mild, being mildly overweight, increases the risk of sleep apnea. So if someone says, well, I'm not morbidly obese, thus I can't have sleep apnea, we have a number of thin patients who do. And again, even that kind of being mildly overweight. And for my patients who are struggling with weight, who have some fatigue and maybe some snoring and sleep apnea is a possibility, I often point out to them that it's almost, when you're not sleeping well and you have untreated sleep apnea, the likelihood of having kind of the mental energy to cook your own meals and to not eat out and to exercise, when someone's not sleeping well and feeling fatigued, these things snowball, right? And then the obesity gets worse, and then the sleep apnea gets worse, and they feel even worse. And I'm sure you've seen these kind of cascades where people are presenting to you with severe sleep apnea, morbid obesity, and this has been something that's kind of been brewing for years and years and years.
Absolutely. And so, when people have a condition that makes them tired and fatigued all the time, it makes it very difficult, I think, to do all the lifestyle things, to exercise and to eat properly, to make those sort of lifestyle changes that would actually help with addressing some of obesity and some of the risk factors for the sleep apnea. So absolutely, we see this sort of situation where things kind of cascade out of control, and the sleep apnea is often part of that.
All right, and after the break, we'll have more with Dr. Lee. All right, welcome back. We're here again with Dr. Christopher Lee, respirologist and sleep disorder specialist at Unity Health, St. Michael's Hospital in Toronto. So let's say someone thinks they might have it based on listening to us today. Run us through kind of what are the steps that someone would take in terms of getting referred, and then what are options for treatment? Can you tell us a little bit about that?
The primary avenue would be through their primary care physician. So they would go see their family doctor and get a referral to a sleep specialist. The usual testing that we do for obstructive sleep apnea is to do an overnight sleep test. The standard here in Ontario is to do an overnight sleep test in a sleep laboratory. And so the patient goes to a facility and spends the night in the lab, connected to some monitoring equipment, and has a test with a technologist in attendance. And so we call this a level 1 sleep study. It's the gold standard investigation for sleep apnea. What happens when you go to the lab is that you usually go there in the evening, and typically in most labs, people show up at around 8 or 9 in the evening, and they would be met by a technologist who is a allied health professional who has expertise in this type of testing. The technologist then sets you up with a bunch of monitoring equipment. And so for the testing, we have leads that go on the head. These are EEG leads that monitor brain waves and tell us about when the patient is asleep and when they're awake and what stage of sleep they're in. It tells us whether or not the patient's in dream sleep, although it doesn't tell us what the dream content is. People are often wondering about that. And then we have a number of other leads that monitor a variety of things. So there's a cannula that sits underneath the nose that measures airflow. There's a couple of other leads on the face to help us with things like eye movements and chin muscle activity. Then we have a couple of bands, one that goes around the chest and one that goes around the abdomen, and that tells us about breathing effort and movements. There is a probe that goes on the finger that monitors oxygen levels. And then there's a couple of leads that go on to the legs, which help us look for repeated leg movements during the night, which sometimes goes along with something called restless leg syndrome, which is a whole other topic. But so we wire you up with all this stuff, and we put you in a bed, and we tell you to go to sleep. Typically, the test is terminated in the morning, usually around 6. All the leads are removed, and the patient can go home. If people need to get up and go to the bathroom during the night, that's not a problem. People are often worried that with all these wires, they're not going to be able to get out of bed. All the wires feed into a sort of one central box, and the one box can be plugged in and out. And so it's quite easy actually to unplug the patient from the monitoring equipment for them to go to the bathroom and then come back and just get plugged back in. And so that's not an issue. People also sometimes worry, understandably, about not being able to sleep in the lab. And we totally get that this is not a normal environment for sleeping. It's not your own bed. As much as possible, we try to make people comfortable there. We tell them to bring their own pajamas, and if they have a special pillow that they like to use, to bring that pillow or a blanket or whatever. But all of this being said, it is a foreign environment, and you've got a bunch of monitoring equipment on you, and that for some people it can be quite difficult to sleep.
The one thing I'll say too, I'll jump in here, is I know patients will tell me in advance that I'll never be able to sleep in that environment, or after the fact saying, well, I didn't sleep a wink, the test can't possibly be useful. But I tell them that what we're looking for in this sleep study in terms of those those apneas, you can't fake those based on not having been able to sleep. So they're fairly definitive that even if someone didn't think they slept a wink, often they'll have slept for long enough to be able to tell us what we need to see them.
Absolutely. And so, yeah, we don't have to see the patient sleeping the entire night for it to be a useful test. even if we see a few hours of sleep, that's often enough for us to tell, and sometimes even less. Sometimes it's immediately obvious to us during the test that the patient has significant sleep apnea, and so we do take into account the fact that it's an unusual environment when we interpret the test. But as you say, the markers of sleep apnea are fairly clear-cut, pretty objective things. And so most of the time, we are able to at least answer that question: does the patient have sleep apnea when they come in for the test?
And it's interesting, again, patients who didn't think they had sleep apnea, I'll see with reports coming back of 30 apneas per hour, 60 apneas per hour, 120 apneas per hour. So again, for you guys out there, that's, stopping breathing for, once every minute, every 2 minutes. And people had no idea this was even happening, which we see frequently on these studies. So let's say someone does the test, they have sleep apnea, and you think Cpap is recommended. Can you tell us a little bit about Cpap, so the treatment for sleep apnea, and kind of what
Sure.
the process is to get that going for patients?
Yeah, so Cpap is by far the most common treatment for obstructive sleep apnea, and it's also by far the most effective treatment that we have. In fact, if you think about it, Cpap might even be one of the most effective treatments that we have for any condition in all of medicine, because it works in pretty much everybody who wears it. The difficulty, of course, is that some people have trouble using it. So just to explain what Cpap is, the term Cpap stands for continuous positive airway pressure, CPAP. And so what this is a mask that people usually wear over the nose, or sometimes just underneath the nostrils. There are some people who have trouble breathing through the nose and use a mask that covers the nose and the mouth, but whatever it looks like, the mask is connected through a flexible tube to a machine. And the machine is essentially an air pump. It just delivers pressurized air into the back of the throat and keeps it open. So it prevents that repetitive airways collapse that is happening in people with obstructive sleep apnea. The good things about Cpap are that, number one, it works really well. As I said, it works in pretty much everybody who wears it. And number two, it also does a very good job of treating snoring. So it treats the snoring as well. We're pretty successful at eliminating snoring in pretty much everybody who wears it. A few caveats about Cpap. It does sometimes take a little while for a person to get used to using a Cpap device. And so there are some people who take to it immediately, but there are others who have to work at it for a little while, and that process can sometimes take weeks to months. The other thing that I always tell people is that the Cpap is a very good treatment for sleep apnea, but it's not a cure. So it's not like you wear the Cpap for a few nights and you're done. If you stop wearing the Cpap machine, you'll just go back to where you started from. So it's typically a nightly long-term treatment, unless something else has changed in the interim. Like you've lost a whole bunch of weight or something like that. Yeah. And then in terms of just the mechanics of going to get a Cpap machine, so a Cpap has to be prescribed by a physician, and typically it's prescribed by a sleep specialist. And so the patient takes the prescription to one of a number of vendors that specialize in selling Cpap equipment. There are many of these vendors out there. And the vendor will then set the patient up with a device. So they'll do some mask fitting with the patient to try to find a comfortable mask and determine which style of mask would work best for that patient. And then they would teach the patient how to use the machine and how to take care of it. And the patient goes home and starts to use it. We will usually follow a patient until they're doing well and comfortable on Cpap and benefiting from it. And sort of help them troubleshoot. Now, most machines these days can actually provide us with some useful data that tells us a bit about how much the patient has been able to use the device and whether there are any problems like leak from the mask or whether there are persistent apneas despite the Cpap. And that helps us sort of figure out whether or not we need to make some adjustments as the patient is getting used to the device.
Yeah, and I always encourage people, if they're having difficulty with a mask, connect back with the vendor, because again, there are different masks and different settings that the vendor can help with. And again, the big thing I tell patients is that if they have sleep apnea and get treated, they will feel so good that they will not be able to imagine not having. They'll notice when they don't use a Cpap for a certain night, they'll know, It'll be that much of a night and day difference for a lot of these individuals who have sleep apnea. Once they're diagnosed, Dr. Lee, so I know that in the past they used to have to go back to the lab for titration, but I know that there's a lot of in-home titrations now. Would you say that's the majority of cases that are being their levels are being titrated at home rather than going back to the lab, or what's the breakdown?
Yeah, one of the things that has become, I would say, more readily available, and the cost has also come down, is these auto titrating devices that you're referring to. So, so with CPAP, there's a fixed pressure device which just delivers the same pressure the whole night, and then there's something called an auto or APAP device, which has the ability to titrate the pressure up and down. And so the device has a way of detecting whether the patient is having apneas or not, and if the patient is having apneas, it'll gradually increase the pressure, and if it thinks that it can decrease the pressure at other times during the night, it'll do so. So it titrates itself according to an algorithm that it has. And so one of the potential benefits of using an automatically adjusting device is that it doesn't treat you with just a high pressure the whole night. So we don't have to set it at a pressure that is effective in all situations. The device can go up and down during the night, and on average, it probably does treat people with slightly lower pressures than we would set for a fixed pressure machine. So that sometimes results in better comfort. And there's also this convenience factor, in the sense that if the device is good at finding the right pressure setting on its own, then we don't have to figure out what the optimal pressure setting is in the lab, or do that repeatedly if the patient's clinical situation changes. And so the thing that probably most commonly leads to changes in a patient's pressure requirements is their weight. And so if the weight goes up, sometimes they need higher pressures, and if the weight goes down, sometimes they need less. And with a fixed pressure machine, we would kind of have to bring the patient back into the lab to find that optimal pressure setting again. With the automatically adjusting device, the device can kind of find it on its own. Now, there are some people in whom the automatically adjusting device is not appropriate, and so people with more complex kind of sleep apnea, people who also have other conditions like lung disease or heart disease, sometimes those patients are not appropriate for an automatically adjusting device. People who have very severe sleep apnea, very low oxygen levels, and sometimes high carbon dioxide levels, these patients are sometimes also much better served by doing a titration test in the lab to sort of figure out A, what the optimal setting is, and B, sometimes we even actually end up using a more specialized or complicated device to treat those patients.
I just wanted to ask a question about cost, because I know that comes up a lot with patients. What does a CPAP actually cost? What's covered by OHIP? What's not? What's what do you tell patients who ask that?
OHIP does cover the cost of a CPAP device through something called the Assistive Devices Program, or ADP. And so ADP licenses the vendors in the province, and they have a set price for a CPAP machine that the vendors all have to be able to sell a machine for. And so currently the set price for a basic CPAP unit is $860. Now ADP covers 75% of that cost. So $645 is covered by ADP. The leftover portion is up to the patient, but having said that, many people who have private health insurance will often have some coverage for that patient portion of the device. And if a person is on Ontario Disability, so on ODSP, or on social assistance on Ontario Works, both of those programs will actually pick up the patient portion of the device as well.
Again, thank you so much for your time today, Dr. Lee, in educating us about sleep apnea. Again, one of the more underappreciated and kind of under-discussed topics in medicine, I would argue, and I'm guessing as a sleep specialist, you would agree. Again, thanks so much for all your help, and thanks for joining us today.
My pleasure, Mary. Thanks for having me on.
Again, thanks to Dr. Christopher Lee for joining us today and providing us such great insight. So again, to emphasize the importance of this. So if you or your partner or family member or friend either stop breathing during the night, snore with fatigue, slightly overweight, but not necessarily overweight, but if you have any of these symptoms that we've talked about, please, please, please talk to your family doctor or your primary care provider about getting a sleep study. find out whether you have sleep apnea, because again, based on my experience, patients who have it, who get treated, feel $1 million better than they did before, and it truly is life-changing. So again, we'll see you next time. Stay healthy.